Okay, I think we can start, and hopefully more people will join as we go along. So good afternoon, everyone, and welcome to today's webinar. Our topic is service user involvement in mental health, and we have amazing speakers today who will share with us tips and tricks how to make user involvement work in practice. My name is Nikolina Jovanović. I'm a psychiatrist with strong interest in engaging service users in every aspect of our work, including mental health care and research. And I used to work in Croatia before moving to London a couple of years ago. And I'm glad that this webinar will have focus on experiences from Southeast Europe, but as you will see, many topics that we're going to discuss today can easily be applicable to other settings. So my role today would be to give you a bit of a background and introduction into this topic, and then moderate this session. So a recorded version of this webinar will be available later, and it will include subtitles in languages from Southeast Europe. Today I will be translating just key points into Croatian to make it easier for people to follow. Pozdrav svima i dobrodošli na ovaj seminar, odnosno webinar, tijekom kojeg ćemo pričati o uključivanju korisnika u različite aspekte mentalnog zdravlja. Moje ime je Nikolina Jovanović i ja ću moderirati ovaj sastanak, a snimka sa titlovima će biti dostupna kasnije za gledanje. Tijekom ovog webinara ja ću samo prevoditi neke ključne točke na hrvatski, što će, nadam se, olakšati praćenje. So for those of you who are just joining us, welcome, and here is today's agenda. So after just a couple of more words of introduction, we will hear from Professor Norman Sartorius on stigma or destigmatization of mental illness. We are very grateful to have Professor Sartorius with us today from Geneva. Many of you will know him as the top expert in the field of mental health, and his presentation will basically be a very good introduction into understanding barriers and how to overcome stigma and other barriers in ensuring meaningful service user involvement. Next, we will hear from Ms. Tihana Majstorović from user-led organization Menssana in Bosnia and Herzegovina about what is service user involvement, or what are the main types of service user involvement, and this will be illustrated by a video from their organization Menssana. Then we will move to another specific aspect of user involvement related to mental health research. We will hear from Ms. Dženana Nikšić, also from Menssana, from Sarajevo, about participating on a panel advising mental health researchers in a large-scale research project called Impulse. And then finally, we have recently published a booklet in which all these points are included. And we will hear from Mina, Aleksić and Mrs. Bosilka Brdar from user-led organization Prostor in Belgrade, in Serbia, about this booklet and why is it important, and what can be relevant for different professionals and service users that we included here. We will end with a Q&A session. Please, as we go along, feel free to put your questions in a Q&A box that you can find at the bottom of your screen, and people can also like questions that are posted, and this will help us to identify popular ones that can be prioritized for answering at the end of webinar. I'm very thankful to researchers from the Impulse project for their help in organizing this event, and particularly to Ms. Tamara Pemovska, without whom we wouldn't be able to do any of this. And she's with us today to help us with the Q&A session and also any technical issues that we might run into. So thank you a lot, Tamara. Okay, so now that you heard from us, we would be very happy to get to know you a little bit more. So we are aware that more than 160 people registered for the webinar from 20 countries all over the world, which is really exciting. But if you don't mind, maybe just putting down why did you sign up for this webinar, and Tamara created this poll that we can run now. Dakle, jako nam je drago što nam se ljudi pridružuju iz cijelog svijeta. Ako želite, molim vas, recite nam zašto ste se odlučili da prisustvujete ovom webinaru. Evo, i mislim da ćemo vrlo brzo moći vidjeti rezultate. I think by now everyone should be able to understand, to see the question on their screen.
Yes, it's launched and people are responding. Maybe just a couple of more seconds to leave time for people to answer.
Okay, so this is what we heard from people. Most people are here to learn about user involvement in research, which is really exciting because this is something that was very unique and new thing that we did, that we want to share with others. But then people also want to learn about user involvement in general and user-led organizations, which could then improve the clinical practice, which is good. No one is in a wrong Zoom meeting, which is great. And then those who want to meet new friends, maybe you can also check our social media accounts, because unfortunately the way these webinars are set up, or Zoom webinars are set up, people can't really see each other and can't interact, unfortunately. Okay, so thank you so much for sharing your thoughts, your reasons for joining today. Let's move on and just emphasize what is the focus of this webinar or learning objectives. So basically, as mentioned before, we will be speaking about the stigmatization of mental illness, different types of service user involvement. Providing peer support is probably very clear to people and something that most people or most services or countries do, but then other types such as co-production of mental health services or advocacy, or being part of research projects and advising researchers on choosing relevant research questions or dissemination of research findings is something that is not regularly implemented. And another really important part of the webinar will be the role of user-led organizations that we will also speak about. Just a couple of more words about the context. As previously mentioned, we wanted to share experience from Southeast Europe. This is a large area with 12 countries and around 70 million people. Countries in this region or part of Europe, they share similar socioeconomic background, but also mental health services are organized in a similar way. And based on some studies that were published in recent years, we know that despite many improvements, mental health care is still focused on hospital-based type of care and limited to medications. Service user involvement and care involvement is something that has been developing and improving, but still there is a lot of work that needs to be done in that area. And this is where this research project called Impulse could be an important driver for change. So the aim of the project is to improve psychosocial treatment of people with psychosis in Southeast Europe. And for this project, we received funding from European Commission, 2.4 million euros, to deliver this work over 3.5 years. And the team involves 9 partners from 6 countries. And these are countries involved in the project. Queen Mary University of London, where Tamara and I are from, is coordinating the project, and research activities are being done in Kosovo, City University of London, Sarajevo, Bosnia and Herzegovina, Serbia, Macedonia, Montenegro, and we have a mixture of academic institutions, clinical academic institutions, and user-led organizations. So very important part of the project was user involvement. We wanted to set up service user advisory panels for the project in each country. And from the very start, we've been working with people. We'll hear from Dženana later about asking for their views and help on every step of the research process. And also we wanted to develop a model of efficient and sustainable user involvement in mental health care, especially in these countries when this is still in infancy, and also resources for this specific work might be limited. So this model, to develop this model, we did a range of activities. One is, as already mentioned, setting up lived experience advisory panels with 6 to 8 service users per country who are meeting with researchers every 3 months. And we are in process of analyzing this work and people's feedback. This will be shown separately. We also explored the role and the way that user-led organizations work, not only in mental health care, but also in diabetes and epilepsy and other parts of healthcare system, just to learn from them what makes them successful, what can be translated into mental health care, how is mental health care different, or user-led organizations in mental health, how are they different? And then we did 2 case studies of two user-led organizations in mental health care to really understand barriers and facilitators for meaningful involvement of users and carers. There was also a workshop with professionals and service users in Tibet in 2019, and all this was brought together in this booklet that will Mina and Bosilka present later, but it's widely available in English and other languages, and I can share the link also in the chat box. So by now you heard that I used some words such as stigma or service user or user-led organization, and when we were preparing this webinar, we thought that it would be helpful to define this terminology before we move on. So I'm just going to leave it here for people to have a look. And in the meantime, I can just say a couple of words in Croatian. Dakle, današnji webinar će pokriti 3 teme, destigmatizaciju psihičkih bolesti, glavne tipove uključivanja korisnika u različite aspekte mentalnog zdravlja i kao jednu posebnu temu koju ulogu imaju udruge korisnika u cijelom tom procesu. A ovo su neki od ključnih pojmova koje ćemo koristiti čitavo vrijeme kada budemo razgovarali o ovim temama. Već imamo jedno pitanje, da li booklet može biti shared, if the booklet can be shared in English. Yes, I will put the link just after I finish my presentation. So thank you so much for your attention. I would like to invite Professor Norman Sartorius to share his slides. And I hope I managed to close mine. So Professor, I think you're on mute. If you could unmute yourself, or maybe I can do it. We can't hear you. You would need to unmute. Yes, it's good now.
Can you hear me now?
Yes, all good.
All right. Well, thank you very much for inviting me. I'm very pleased to see this project, and I'm delighted to have an opportunity to tell you about the experience which we gained over the years that we work on stigma. In fact, the first major international program against stigma started in 1993 when I became president of the World Psychiatric Association. And when we decided that it would be important to have one central project, and we were thinking, what is the main issue in the whole area of mental health care? And as we were thinking about it, it became obvious to us that it is in fact stigma. So we started a program which was called Open the Doors, because its purpose was to open the door of people to people who had mental illness and who, because of it, have been excluded from society and left with enormous numbers of problems. And 23 countries participated in this program. We have learned a great deal from them, and I'll tell you some of the experience which we had gained in the course of the program. Now, looking at what happens in recent times, we see that there is a number of good news around. First, several countries have developed very effective programs against stigma, and I'm listing them here on this slide, from Australia in the south to Brazil and Canada, Czech Republic, Denmark, England, Hong Kong, Germany. All sorts of countries have done this, as well as more countries which have declared that they are going to start programs against stigma, having seen that this is a program that is necessary and essential if you want to make progress. So this is good news. Good news is also that the United Nations, for the first time, decided that they would do something about mentally ill people who are on staff of the United Nations as well. And they started the program anti-stigma concerned with their own staff. While at the same time, the Secretary General of the United Nations has spoken about the need to do something about mental illness and about mental health, because that is an absolute forgotten priority for all countries in the world, and in particular for countries with limited resources. And ministers of health have more recently started to understand that this is also very important, and I listed here one of the particular meetings this year in the Netherlands, in which the ministers came together and said that they have to do something, and were thinking about what they could do to in fact reduce stigma. Unfortunately, in my opinion, it is probable that the stigma of mental illness will continue to grow, and that its consequences will become even more pernicious than they are until now. On one hand, because in most countries of the world, there is an increase of competitiveness. You have to do more and more to be recognized. You have to you find yourself in great competition for jobs and for everything else. At the same time, while the competitiveness of societies has grown, the government's resources in general for health in proportion has gone down. There is more and more ideas that we have to leave the people to look after their own health. And that, of course, is possible if you have a lot of money, but many people who are sick do not have very much money. And so that generally we feel that the promotion of health has been reduced in the total amount of money that is being given to it, although the language, the words, have become much more positive. And one of the reasons for it has been the growth of private and for-profit health services, in which maybe until now, they didn't play such an important role. But gradually they are taking over more and more of the healthcare service. And of course, for them, the work with stigma is not a priority, which is in a way a work priority for governments and for people who think about public health in general. Private care works on the principle of commoditification, on a principle that we are not going to do anything that is not going to return funds, money. And that, of course, is in principle true also for the field of psychiatry, but not immediately. We have to, in fact, invest into the system. We have to invest into people's health before we can hope that that will be a significant return from these efforts. It is also likely that stigma will be enhanced not only because of this commoditification of medicine. Commoditification is a word that has been used to describe that everything is being considered as a commodity, like sugar or cotton or wood. And basically, it says, I will buy health and I will sell health. And that, of course, is an attitude from which the noble imperative that we have to do something about people's health has gone. Then there is also the problem that communities have broken down in most parts of the world. In a country like Argentina, now there are 95% of the population lives in towns, and most of them have moved in the last 15 to 20 years. And people, when they came to towns and when the country is urbanizing, urban settings do not know communities. They are not that people are living on the same territory, that they're sharing the same water source, that they're meeting each other in church or in a mosque or somewhere else every week or every day. No, towns are anonymous. They are not very congenial. They are not making it easy to create communities. And we have forgotten that. We still speak about community care as if the model of communities that exist are well defined, in which people know each other and relate to each other, help each other, exist. But they are not that anymore. There are now new types of communities. The electronic community, for example, is one of them. And families as well have restructured themselves in many ways and have become, well, less powerful in the support. Think of the laws which have recently been enacted in Bangladesh, for example, or in China or in other countries, in which children who refuse to look after their parents will be fined and put in prison, because it has become so frequent that they are not looking after their parents when they are, the parents are aged and perhaps without any resources. In addition to this, there is also an increasing complexity of labor, which more or less has led to difficulties in re-employing people who have lost practice and for years have not been working in any job and now have to re-enter a very competitive market. So things are not all good. There are many problems that we see. So the question, at the same time, while this is happening, the stigma of mental illness has grown. And we have to ask ourselves whether the postulates of anti-stigma work, which we have formulated in the 20th century, are still valid, or whether the research and experience which we have gained over the past 5 decades have in fact continued to support them, or maybe we have to change them. Let me now go through the 5 or 6 main postulates of stigma work to see whether these postulates, these rules, are still valid and still relevant. The first postulate was that if you want to work something against stigma, you must make a long-term plan, and you will base this work on the results of research, and having examined what the situation is like, you will create a program which will have its deadlines, it will have its time posts, it will be planned into the future. Now, is this still true? I don't think so. I think that in many places there was no research. So what should we do now? Wait until research brought enough results? And most studies also that we have been dealing with large populations. And since they're dealing with large populations, they speak of averages, but they are not relevant to the local situation. In my life, I've never met an average person. They're all different. And equally so, all communities are different. And results from large studies do not, in fact, help very much in particular program. The research would have to be done locally in the very community in which we are trying to work. We know today that it's the people who know most about mental illness and know most what is disturbing them, and are people who have experienced mental illness, and people who are looking after them, their families or other carers. And so gradually we have understood it's there where we have to seek information rather than in long-term research. We have to think about ways in which we can involve the people who experience mental illness, who suffered because of it, to tell us what is it that disturbs them most? What is it that they feel they must put on top of the priority list because it is the most greatest problem for them? We've done this in several of our countries, and we were surprised that many of the priorities that research has indicated have not been equal to the priorities indicated by the people. In Canada, for example, we have been thinking that it is we have to change the way in which people speak about mental health, speak to journalists, etc. But when we asked the people who had mental illness what is disturbing them most, they said, we are significantly discriminated in the health service. When people hear that we are mentally ill, they don't give us care as they give to other people for physical illness. We are making to wait longer. They don't believe us, etc. And it goes on like this. So we, instead of organizing our program to deal with these things that the research told us, we concentrated on changing particularly healthcare services, and that had a positive result. And in fact, also enabled us to involve people who experience mental illness to become the most ardent and strongest supporters of the program in the country. I've also listed down here what we call the strategy of enlightened opportunity. A program against stigma can be best built when one uses the opportunities that emerge. When the President Kennedy had a nephew who was mentally retarded, it was the best time to do research about mental retardation and to do something for people with mental retardation. And equally so, when there are opportunities for one reason or another, we have to be ready to jump and use them, which means that the long-term plans must only indicate that we must be ready to do something when an opportunity arises. Now, the second postulate of stigma, which was accepted, was that programs against stigma should be measured by the change of attitudes to mental illness. Do people now think differently about mentally ill people? And as we went along and as we examined and listened, we discovered it is not true. First, because attitudes do not predict behavior. People, you ask them, would you be willing to work with somebody who has experienced mental illness? They say, of course. But then you bring somebody who had mental illness to them, they don't want him. You come to leaders of health services who speak against, fighting against stigma. But when you look to see how many of their employees have in fact had mental illness, you see there's none, because they didn't want to employ them. So I think that notion that an attitude is a good measure is not right. What we have to use as a measure is actual change of people's behavior, changes of laws, changes of the budget for mental health, because that is the true indicator that we have achieved something, not attitude measurement. We have also been convinced previously that we will have to improve the knowledge about mental illness and that this will diminish stigma and discrimination. We will tell people what schizophrenia is, we'll tell them what is manic depressive illness, we will tell them this, that, and the other, and that will decrease stigma. No. In fact, stigma very often becomes worse when information about illness is provided. We can educate people on what to do when they see somebody who is having mental health problems and how to help that person. That is an all right education. But basically, when you have a group of people who are prejudiced and who think about mentally ill people as being bad, whatever you tell them, they will only remember what is in harmony with their prejudice. I'll give you an example. If you say of 100 people, 10 who are without any mental illness will commit a crime, while 100 people who have a mental illness, only 5 will commit a crime. 2 times less. What does a prejudiced person remember? He remembers 5 people with mental illness commit crimes. They remember only what is confirming what they believe anyway. So you have to think differently about education. Education is to come as a consequence of a changed attitude. When people say, yes, I would like to know more. Education comes to carers, where very often we can offer knowledge that is helpful in their learning how to live together with a person with mental illness. Education is helpful when the attitudes have changed, when people are ready to accept and do something together. We have also been thinking that placement of people with mental illness into their community will destigmatize psychiatry and mental illness. And it turns out that that is not the fact. First, because I mentioned earlier, the communities of the 1960s, when these rules were invented, are vanishing and they are taking new form. And I think that we should gradually think of who is in fact creating attitudes and prejudice. It is more useful to tell parents to educate their children when they are 3 years of age that they must accept people who are different, because that is the point where attitudes are created. We have to continue with the same principle of thinking in schools. How do people behave to children who are different? And continue later at the workplace. But it is not possible to just do it later. It has to begin early. And attitudes and acceptance of people has to become normal part of our education of children, of our education of the adolescents and of everybody else. And it is amazing when you do it, how strong a support you get, particularly from adolescents. We have seen that, for example, when people with mental illness are in direct contact and come as teachers to talk with people in schools, it's an amazing change of attitude that happens. And it happens in a young person much more than it will happen in a person who is already, so to say, affirming his attitude and ideas. We've also been saying that well-focused campaigns against stigma are the best way of reducing stigma. Stigma, including all of the negative prejudice that people have about people with mental illness. Well, turned out that that is not true. Short-term campaigns leave very little trace in the attitudes and the behavior of people. They hit and then they vanish. And next month, there is another campaign about another illness. And people with mental illness feel, in fact, hurt by the fact that attention to them has vanished, gone, is not there anymore. We have to think of ways in which the social contact between people who have mental illness and other people will become a permanent feature of society, because that is where people learn that their prejudice was wrong. We have also been saying we have to really hit the population with anti-stigma messages. Largest possible audience, in newspapers, in streetcars, in tramways, in buses. Every mental illness is like any other illness, similar thing. Well, it's not true. The population in general has different needs, and they view diseases in different ways. And we have to think about educating people specifically to the field in which they work. When we are educating policemen, we have to educate them different from teachers. When we educate judges, we have to think what is a judge doing in his life and what he will be suing, because that is the way that we can orient the training to specific behavioral changes which we want to achieve. And we've seen that specific courses that have been given to teachers, policemen, judges, nurses, others have been very effective, while the general education and general messages have had very little effect. So this is a summary of what I told you. We now know that the selection of targets for a program on stigma must be based not on the evidence based on studies, although they are useful as well, but on a discussion with people who live and who have lived with mental illness and their families. We should not, as a program, address the whole population, but define groups whom we are going to hit and specifically educate. We should not think of a program as lasting for 3 years, but forever. It's a normal part of health care to think about stigma. We have been thinking that we should evaluate programs by change of attitudes, but it's not that. We want to see the change in funding, the change in laws, the change in services, to believe that something is being done. We have been thinking that we should educate people by giving them health literacy. The education now has to be primarily given to raising the self-esteem of people who are mentally ill. They are valuable and they stop believing it. And I think that's something that we must keep in mind. This is a great enemy, the self-stigmatization, which we have to overcome, because people have value and they stop believing that they have it. We have been thinking that we should change the attitudes of the general population, but what we really want, we don't want to change of attitude only, we want to eliminate discrimination, and we have to decrease the social distance. And the eventual goal is not to increase tolerance for people with mental illness. I'm tolerating woods and stones. The real goal is to include people with mental illness back into their family, into their community, into their workplace, and so forth. So, ladies and gentlemen, stigma is still the main obstacle to better mental health care and to creating a more noble society. I think that the first step that we have to take is to ask ourselves, what do I think about people with mental illness? What would I do if I were faced to judge? Will I be willing to in fact live by what I teach? But the most important message which we have shown in so many countries is that action against stigma can be successful in all settings. Countries poor and rich, countries large and small, villages and towns, enterprises and old age homes. No matter where, it is possible to change it, and we can be successful in this respect. I thank you very much for your attention.
Thank you very much, Professor, for your very insightful and inspiring presentation. We will have time later for questions, but please post them even now if you have. I will try to summarize this in Croatian, but before I start, a couple of questions were related to information that we already mentioned, and where can people find that. So I'm just going to put here that these are our social media channels, and everything that we mentioned before can be found here, including a recording of today's webinar. Before we go on to the next presenter, I'm just going to summarize quickly. Profesor Sartorius je izlagao o borbi protiv stigme, protiv mentalnih bolesti, odnosno stigmatiziranja mentalnih bolesnika, i zapravo dao smjernice kako tome pristupiti, koji su postulati bili do sada prisutni, a kako u našem društvu 21. stoljeća, koje se neprestano mijenja, se to može zapravo raditi puno učinkovitije i kako nove kampanje trebaju biti vrlo fleksibilne, kako je potrebno početi od samog sebe i naći prave ljude koji mogu iznijeti promjenu, a i to je vrlo važno za naglasiti da promjena zapravo nije i ne trebaju tražiti ili poticati u stavovima ljudi, u mijenjanju stavova ljudi, nego baš u konkretnom ponašanju, promjeni ponašanja, što se može vidjeti kroz zapošljavanje ljudi sa mentalnim bolestima ili kroz promjene u financiranju službi mentalnog zdravlja, i mijenjanju naravno politika koje se odnose na poboljšanje statusa ljudi koji pate od mentalnih bolesti. Eto, toliko za sada. Hvala profesore još jednom. Imamo još jedan komentar od Tamare Radojičić koja kaže: Thank you, Professor Sartorius. It was a great presentation and an insightful overview of overlooked issues in efforts to fight stigma against mental illness. Tamara is from Montenegro, one of researchers on the Impulse study. Thank you so much. We are now moving to our colleagues from user-led organization Menssana in Sarajevo, in Bosnia and Herzegovina. And we want to hear from Tihana and Dženana. You have prepared your presentations and a video about your organization. So please, Tihana, go ahead. Thank you.
Hello to everyone. My name is Tihana. I'm a psychologist and psychotherapist, and I'm also project manager in a user-led organization, Menssana, in Sarajevo, Bosnia and Herzegovina. Before we start to talk about our presentation and our topic, we would like to share a video clip, a short movie about Menssana. That was published during the Impulse project. Just to make a short intro, our way of fighting stigma is really including users in organizational management, in project activities, in project leading. So we do that in a partnership, like as professionals and users. It was started during the former Yugoslavia. The healthcare system and psychiatric care was quite centralized in hospitals and connected to hospitals. And after the war, that changed everything. The reform of mental health system was started by mostly by project of mental health and association Nikšić, funded by a Swiss development agency. And in 1211, they founded 20 or 30 user-led organizations around Bosnia, in users and professionals in mental health together founded organizations. And one of those organizations is Menssana. So just you will get to know better through the video.
Okay, yeah, would you like me to share now my screen? One second. Are you able to see that all right? Yeah.
Yes.
Okay.
Ja sam Aleksić, korisnica udruženja Menssana. Počela sam dolaz prije 2 mjeseca i udruženje mi je mnogo pomoglo da se vratim na staro i počela sam puno učestvovati u sekcijama, u aktivnostima. U razgovoru sa Tihanom vratila sam se na staru još čvrsta i bolja. Eldina je tu da mi pomogne da se vrati fizički, tako da u suštini ovo udruženje mi je mnogo pomoglo da se i psihički i fizički vratim da budem i jača i spretnija i sve, tako da nadam se da će i dalje nastaviti udruženje raditi, da ćemo još više članova dobiti i da ću ja nastaviti sama da budem još bolja i s pomoć i psihologa i Eldini i ovih žena što dolaze.
Kako si me, Elvira? Da dam dobro se. Da vam bilo je dobro jučer na vežbama. Just. Drage moje cure, hoćemo vježbu? Hoćemo. Opustite se i duboko udah na nos. Zadržite dah 3 sekunde, izdah na usta 2. 6, 2 i 10, 2. Možete otvoriti oči, podići obje ruke, 3, 2, 1, spustimo 2. Dubok udah na nos.
Ja sam Nikšić, diplomirani sam fizioterapeut. Angažovana sam u udruženju za zaštitu mentalnog zdravlja Menssana kao koordinator sportsko-rekreativnih terapijskih vježbi. Također učestvujem u planiranju aktivnosti vježbe na otvorenom u prirodi jer vrlo često angažujemo i planiramo izlete i vježbe na otvorenom. Što se tiče samih vježbi, oni predstavljaju jedan temelj za zdraviji i kvalitetniji način života. Sportsko-rekreativne i terapijske vježbe, one nam pomažu i razvijaju i održavaju funkciju ljudskog kretanja i kvaliteta života. Jedan sport predstavlja jedan vid prevencije za unapređenje zdravlja.
Ja sam Šetić, predsjednik Udruženja za zaštitu mentalnog zdravlja Menssana. Udruženje Menssana nastalo je 2012. godine. Udruženje su osnovali korisnici usluga u mentalnom zdravlju i profesionalci u mentalnom zdravlju. U svom dosadašnjem radu proveli smo niz anti-stigma kampanja, istraživačkih projekata, a posebno smo pažnju obratili na projekte koji jačaju kvalitet života osoba koji imaju poteškoće sa mentalnim zdravljem. Sve dosadašnje aktivnosti smo proveli zahvaljujući financijskim sredstvima koje daje projekat mentalnog zdravlja i Švicarska razvojna agencija, zatim Europska komisija i niz projekata koji smo realizirali u saradnji sa lokalnom zajednicom, posebno sa općinom Stari grad.
Thank you, Tamara, for your help. So that was a short presentation of our association. Now we would like to just present a few basic terms such as service users, user-led organization, and just to connect it with the topic. So what is service user involvement? So first we need to define a service user. In this context, it refers to a person that was or still is a part of the healthcare system, as she or he was using services for mental health protection and rehabilitation. In a traditional form, these user services are referred as patients or psychiatric patients, but now we're using users because they're using services. So those services can be provided in formal mental health care system, such as state hospitals, clinical centers, and clinics. But services can also be based in communities, such as community-based services. And in this moment, according to our knowledge, service involvement is more common in community-based services. So service users are more able to participate in their healthcare system through the community-based services such as user-led organizations. So in which ways users in mental health and caregivers can be included, or in which way they can show their involvement. One of the really important way is direct help for other users, because most of the time when we connect people who live with mental health illness for I don't know, 20 or 30 years with people who are just discovering their specific mental health condition, it is really useful for the new ones, and it can be really helpful for them to see that other people can function quite successfully, have families and jobs, but also to be service care users for years that do use pharmacotherapy in the same time. The other form is really important. It is participation in legal legislative process due to mental health issues. It can be referred to advocacy, such in politics and legislative, but also to services and boards in the mental health institutions. Nikolina was mentioned the survey that explored user-led organization in the region countries, and we compare results from service of mental health and other issues like physical health, and the other organizations are more active in legal advocacy and the participation in the legal legislative process in cooperation to mental health issues. That is where we see really space for improvement in the region. And the third role of user involvement is to be expertise and to be seen as experts by experience in research projects related to mental health, such as was the Impulse project. User-led organizations tend to summarize those three aspects of user involvement. They are founded and run by people who use support services, their family and caregivers, and also in partnership with professionals. There are different types of user-led organizations. Some of them are founded and run strictly by users, and they only consult professionals when necessary, such as external experts. But most of user-led organizations, especially in Southeast Europe is founded and led in partnership of professionals in mental health and users. So it's like a joint process. Goals of the user-led organizations are for mental health users to take more active role in creating adequate services for others, to be a part of local community, and to reduce a number of hospitalizations and risk of hospitalizations. And it is also important to get more involved in real life and not only in hospital treatment and their own family, just to spread the spread the communication on other people. So service user is important for all different kinds of people who are involved. It is important for users that are helping, because as we were able to see, and Dženana will also talk about that, especially during the LEAP meetings, service users who are helping others are developing new roles, because they are not only receiving help such as they were treated for years before, but they also can contribute and make a sense of their experience. They can use their experience, a unique experience, to help others and to give a sense and understanding of their own trauma in a different way. For users that are receiving help from other users, usually people who are just have had their first hospitalization, or just they encountered mental health system for the first time. They are gaining trust. They're easily, it's more easier for them to connect with other users than with professionals in the first moment. They are having a model because they see people who function for 10 or 20 or 30 years successfully with mental health diagnosis. So it also gives them a hope and different model, different image of their own future. And for professionals in mental health, stakeholders and researchers, it is gaining a completely new perspective and keeping in touch with reality, insight in real needs of people who are using mental health services. Professor Sartorius was also talking about difference with getting information from a study and research on the one hand, and on the other hand, from experience and caregivers and patients in need, in real need. So we tend to connect those two, really, to have a research, but also research that is based on real life experience, but by our users. What I would like to add, that in Menssana, every day we are witnessing that we are changing roles. So every professional in mental health that was service provider at one time can easily become a service user. And also every one of our service users can be really helpful and easily get in touch with their helping role and the role of the helper. So it is leading and living in user-led organization is really based on being aware that each of us has really different roles, and really have trust in helping capacities and roles of our service users.
Thank you very much, Tihana, for sharing your experience from working for years in user-led organizations, Menssana. This video was also very interesting. We have some questions that we're gonna go to later. We will now go to Dženana. Dženana can prepare herself. Before that, I'll just summarize Tihana's presentation in Croatian. Znači, Tihana nam je prezentirala rad udruženja korisnika Menssana u Sarajevu. Vidjeli smo video koji sa direktnim iskustvima i profesionalaca i korisnika, ali nam je Tihana i rekla koji su glavni tipovi na koji se korisnici mogu uključiti da bi unaprijedili mentalno zdravlje, odnosno službe mentalnog zdravlja. Jedno je direktna podrška, kada se netko ko se možda tek razbolio može spojiti sa mentorom koji se već godinama liječi i može mu pomoći svojim direktnim iskustvom, ali osim toga isto tako korisnici mogu savjetovati i kliničare i političare i istraživače o tome što je relevantno za njih i što bi trebalo zapravo, na što bi se trebalo fokusirati u njihovom radu. I u tome se uloge isprepliču između korisnika i profesionalaca i vjerojatno iz toga izlazi ta jedna nova vrijednost koju smo vidjeli i kroz ovaj video. Hvala puno Tihana još jedan put. Ja ću sada najaviti Dženanu. Znači Dženana was a member of Lived Experience Advisory Panels, so a group of people in Sarajevo, in Bosnia and Herzegovina, who was advising researchers on the Impulse project on different aspects of research, how to phrase questions for people that we wanted to interview during the clinical study, or what to do with findings that we have from after data was analyzed, how to best disseminate those findings, who to approach, and so on. So they were very active. They have been very active. The project is still ongoing, and I know that Dženana worked with her colleagues from this group. They worked together on this presentation that Dženana is gonna tell us about now. So yes, please go ahead, Dženana. Evo, molim vas, vi recite što ste pripremili. Hvala.
Ja sam Nikšić Dženana, članica udruženja Menssana i Lipa. Vodič za razvoj naziva Hajde da radimo zajedno obrađuje, objašnjava i prikazuje stvarno stanje pacijenta sa mentalnim problemima u našoj zemlji i zemljama regiona.
So my name is Dženana Nikšić. I'm member of Association of Menssana and LEAP group. I would like to say something about our booklet that was showed before, Let's Work Together. It really explains a real condition of patients with mental health issues in our country and the region country.
Pažljivo sam pročitala knjigu koja daje zaista dosta informacija iz ove oblasti i što je vrlo važno, čitko i razumljivo kao i pristupačno pacijentu i široj javnosti.
So I read this booklet carefully. It really gives a lot of information and it is understandable to a patient and caregivers and other and wider public, wider community.
Kroz vodič sam se informisala i prijatno iznenadila da postoji više udruženja u Sarajevu i u drugim gradovima susjednih zemalja.
I was surprised when I found in the booklet that there are other associations in Sarajevo and other countries in the region that deal with mental health users or user-led organizations.
Zbog nedostatka vremena, obzirom da sam zaposlena, nemam priliku često posjećivati naše udruženje, ali svaki dolazak u Menssanu je jako prijatan, ugodan i osjetim domaću atmosferu sa divnim ljudima i lijepim druženjima.
I'm not in Menssana often because I am employed and I don't have really much time to join the activities, but I found every arrival at Menssana as comfortable and I feel like at home with wonderful people and in social contact.
Učesnik sam u projektu Impulse za koji imam zaista najljepše iskustvo od stručnjaka koji vode projekat do učesnika koji su prijatni i sa kojima mogu razmijeniti iskustva liječenja i družiti se.
I participate in Impulse project in Menssana and it is really most wonderful experience. I'm satisfied with experts who are leading projects and other lead members that are really comfortable and I can exchange experience about treatment and hospitals and socialize with them.
Nadam se da će kroz projekat Impulse poboljšati komunikacija na relaciji pacijent-ljekar, bolje pratiti stanje pacijenta i da će motivirati da se što više koristi u narednom periodu.
I hope that Project Impulse will improve communication between doctors and patients, and to follow up patients much more better. And it will be that the doctors will be motivated to use Project Impulse results as much as it is possible.
Čitajući ovu brošuru, upoznala sam se s radom, proširila znanja u brizi za mentalno zdravlje, kao i nadu da će se sve više raditi na očuvanju i poboljšanju mentalnog zdravlja na našem širom području.
By reading this booklet and being part of Impulse study and lead, I'm more familiar with the process of work, with the mental health care system, and I hope it will be it will result in a further improvement of mental health in our country and wider.
Hvala za sve što činite i što ćete činiti za nas u ovim teškim vremenima.
So thank you for all the efforts.
Pošto su ostali članovi LP tima aktivni članovi udruženja Menssana, sa svog stanovišta mogu potvrditi pozitivne učinke u svim sekcijama udruženja i u vlastitom životu.
So the other members of LEAP team are more active in Menssana, so they also can confirm that the coming to Menssana and to LEAP meetings has a positive effect to them and their own life.
Bilo bi dobro da udruženje nastavi sa radom jer mnogo pomaže u svim segmentima života.
It is important for Menssana to carry on with the work because it is helpful with all the aspects of the life. That's it.
Thank you very much, Dženana, and your colleagues for sharing your experience. Hvala puno, Dženana, i vama i vašim kolegama što ste podijelili s nama vaše iskustva sudjelovanja i u ovom projektu i u istraživačkom procesu. Doći ćemo vjerojatno kasnije sa još nekim pitanjima. A sada se polako približavamo zadnjoj prezentaciji i onda ćemo imati vremena za pitanja i odgovore. So thank you again. We have our final presentation now, and then we have time for discussion. So next is Ms. Mina Aleksić from user-led organization Prostor, and I think Bosilka, Mrs. Bosilka Brdar is with you, and probably a couple of other people, Mina, right?
Yes, Bosilka and Aca are here, but I'm not sure he will be able to stay until the end. But Bosilka will address the participants. Okay, so I can start. Hi, everyone. I'm Mina Aleksić. I'm an art therapist and the president of Association Prostor from Belgrade, Serbia. We actually started as a volunteering organization in psychiatric institutions, like a group of artists and psychiatrists. And we were providing people with the opportunity to create art in order to facilitate communication with themselves individually and with the broader community, actually, through their art. So we were basically an artistic organization in the beginning, but this was 10 years ago. So in the meantime, we started doing like educational projects, community projects, and also to participate in the Impulse project, which is our first research project. We are not like a user-led organization in a strict sense of word, because we are actually led by artists and psychiatrists, as I said. And we have many volunteers, psychologists, and now we have also a social worker and similar professions. But the users are treated as experts by experience in our association. So we actually ask them for their opinion on every matter concerning the activities, their involvement, and actually the quality of services that we provide. So in this sense, we are a user-led organization. So later I will present our video where the users actually speak about two existing real user organizations here in Belgrade, which are called Videa and Duša, and a little bit about Prostor also. And there is this whole network of user-led organizations in Serbia called Naum. In each city where there is a bigger psychiatric institution, there is also an user-led organization, but they need really an encouragement and empowerment. So only now in Serbia, there are some more projects regarding mental health. So I hope that this network of like serious user-led organizations where people who are experts by experience have their leading positions and the ability to change things from their own perspective and to really do something and change the system. So as Tihana said, there is a process of a reform of mental health system going on. So finally, also with this situation where unfortunately Corona kind of pointed out the importance of mental health, I have a feeling that mental health finally started to be an important issue in our society. So we are also doing some anti-stigma campaigns and raising public awareness on mental health issues. And now we have this space in the center of Belgrade where we have regular activities. So we are funded project-based and we live from project to project, and hopefully we will manage to change something through advocacy and through collaboration with institutions and the government, hopefully at some point. So now I will speak a little bit about this booklet that we wrote and published within the Impulse project. It's called Let's Work Together in English, and Hajde da radimo zajedno. It's a guide, as you already mentioned, for better successful inclusion of psychiatric care users in research and in mental health system in general. So I will share my screen now. Do you see it?
Yes, we see it. Yeah, excellent.
Thanks. Okay. So it was published in October 2020, and these are the authors. So I just want to mention also Mirjana Zebić from Clinical Center of Serbia, who really helped us a lot, because UBEO team from Medical University of Belgrade was a partner also in Impulse project, and Remzija Šetić from Menssana. So Nikolina, Tihana, and I are here already. So it was published in all 6 languages in all partner countries. So here we spoke about what is the user-led organization, which you already know by now. And we were talking a little bit about how the user-led organizations are funded and led in other countries where there are like really examples of good practice, like in the UK or the Netherlands. So we're giving some examples of this. And also we spoke about Menssana and Prostor. We listed our activities, we listed main challenges that we face in our work, and maybe some recommendations for the new user-led organizations on how to set the structure of the organization in the beginning, with all the recommendations on how to fund themselves, who to communicate with, and what are our good examples of good practice. Then we did one kind of small research. Actually, we sent the questionnaires to all the existing user-led organizations in the region, in ex-Yugoslavia. And we did this research where we drew some conclusions about what are the necessary steps and maybe the main healthy foundation for a user-led organization, which I will show you in the end. We had an opportunity in the Impulse project to meet in Tivat, Montenegro. This was really a lovely workshop where we met with all the representatives of LEAP groups from the whole region. And we had this workshop. It was in September 2019. And all the users show really like an interest and enthusiasm to make this network on a regional level and to continue communicating, and maybe also to try some mutual projects in the future, and to continue this collaboration that was born in this Impulse project. And also in this project, we have to deliver this model for successful and sustained user involvement, which will be this really ambitious document, where it's like actually this booklet is like a small model, which is more understandable and comprehensible to the wider public. So the model will be really a serious document with all these details. So we got some valuable feedback from professionals and users from the region and also from London. So the mostly positive comments, that is useful, that it is understandable and simple, so everybody can understand it. It can be read both by users and by professionals, that the design is nice. And for me also, that's why I made it bold. I bolded the letters, because the term expert by experience for me makes sense. Also, Prostor is a member of Hearing Voices movement on the international level. So the personal experience is valued really a lot in this movement. So for me, I think that these people, they know best what they go through and how their experience looks like. So also peer support is based on this term. So I think that people with psychiatric experience can be best experts and support the others. So both professionals and users can benefit, and there are many useful concrete advice for new user organizations. So these are some reviews that we got from different countries. I think there is one on English from Dr. Susan Collinson, and these other ones in our languages. So I will now invite Bosiljka to tell us. Bosiljka is a member of user-led organization Duša and also member of Prostor, and she's an artist, and she will now tell us a little bit about her opinion on the booklet. So I will let her hear so you can hear her maybe better. And I will translate.
Čitajući ovu brošuru, primetila sam da je veoma razumljiva i kao korisnik psihijatrijskih usluga i kao član korisničkog udruženja mislim da je prikazan realno stanje u našem mentalnom sistemu.
So as a user of psychiatric services, when I was reading this booklet, I understood that it's really comprehensible and clear, and that it represents really realistically the situation in our mental health system.
Ova brošura može da bude ne samo informativna za nas korisnike, već može da bude i podstrek da aktivno učestvujemo u rešavanju naših problema i podizanju svesti.
This booklet can be used not only as a source of really valuable information, but it can help us to be more active as users and to help us raise public awareness on this subject.
I meni je veoma drago što se radi na podizanju svesti o mentalnom zdravlju.
And I'm really glad that finally we are working on raising public awareness on mental health issues. Thank you. Okay. So these are some pictures from Tivat Montenegro workshop. This is all the LEAP members and the LEAP coordinators that met in Tivat. This is the psychodrama workshop led by Tihana Majstorović, which was really useful for us because it was out of a serious research and, educational context. It really kind of shook our boundaries. So we really felt like a team in this situation. Then later I led the art therapy workshop where we did some conclusions, and each one had their insight about what are the future steps and how we can work together in order to make the whole impulse story maybe develop further after the project is finished, and to help the LEAP groups develop further. So actually some recommendations. So first, that the user involvement case can advance the position of people with mental health problems in society, because as I said, their expertise is unique. And I think that in user-led organizations, there must be like really an important role of users, but also with the assistance of volunteers, of students, of professionals, so that the organization can function in a best way possible. So there are many also user-led organizations in the region that really are kind of stuck because they don't have the abilities to write projects, to network with the organizations from abroad, and so this is why maybe some help with administration and these kind of issues like writing projects and management are really useful. So that's why also everybody, all the actors must join together in order to support these organizations. So we came in this workshop in Tivat, we came to some, and through these questionnaires, we came to some important aspects of user-led organizations that are necessary in order to provide resources and to make these organizations sustainable. So they have to be initiated by open-minded professionals, and it has to cooperate strongly with the users, so to ask their opinion on everything. And the role of volunteers is really also important. Then to have respect for users' capacities, needs, abilities, and desired roles, because as we know, there are many users who really don't feel they're ready yet to enroll in a more serious way or to spend their energy in some roles that maybe they are not used to. So maybe to empower them to take these roles later, but in the beginning, just to kind of follow what are their needs and abilities. To define the roles best, so we avoid burnout also. To work in the community, because it's nice also to support some kind of alternative works within the institution. But the main thing is to move the focus from the institution to the community in order to change this strictly medical perspective and to change the opinion of the society. We also need to get the support from the local community. The only way to do this is by campaigning, advocacy, and also this is something that needs to be done in collaboration between users and professionals. It would be good to employ at least one person, because from our own opinion, burnout and also of course, people who are volunteering for many years, they need to get a job, they need to live their lives. So it's difficult to be a volunteer for many, many years. Then continuous education, development and supervision. It's important to get the examples from a good practice from abroad, to get training, to get supervision, because you can get stuck in your own frame of mind if you don't work further on all these abilities. Cooperation with the healthcare system, where also like the NGO is like kind of in a difficulty, because sometimes we are characterized as anti-psychiatry, but this is not what we are. We are supposed to cooperate with the mental health care system in order to provide this compliance between the professionals and us in the community and the users, because also psychiatrists are very important. They have a very important role in the life of users. So educated and dedicated volunteers, and also to build the expertise and strength of users to provide peer support, and to also campaign together with us, and to participate in the advocacy activities and similar. And of course, now in the Impulse project, we have this good example where the LEAP groups, they were really, the members of our LEAP group and also in other countries were really motivated and they participated actively. So also this participation in research project is something new for this region, and I think it's really valuable experience for both sides. And this is it. So I would ask Tamara to play the video. So first, wait 1 second. So first, the president of user-led organization Videa will speak a little bit. Then one member of Duša will speak about Duša user-led organization and about Prostor activities.
Yeah.
And I need to stop sharing. Right?
Yes, please. And I should be able to share the video.
Pause, share, stop share. Okay.
Okay. I hope you can see that. Okay.
Ja sam Marina Marković, predsjednik udruženja Videa i korisnik psihijatrijskih usluga. Naše udruženje se nalazi u Beogradu. Nastalo je 2008. godine na inicijativu bivših korisnika dnevne bolnice, bolnice za psihijatriju KBC-a dr. Dragiša Mišović i uz pomoć tadašnjeg osoblja dnevne bolnice. Na početku nije imalo svoj prostor, koristili smo prostor raznih organizacija koje su bile rade da nam pomognu. Onda smo, uz pomoć opštine Čukarica uspeli da dođemo do ovog prostora. Udruženje pomažu tako što organizuje aktivnosti na kojima mogu ljudi da se okupe i da se druže, jer to je dobar početak, posebno posle bolničkog lečenja, da kažem, u nekoj sredini koja je manje osuđujuća, steknu neke snage i volju da se druže sa drugim ljudima, jer ljudi su u suštini socijalna bića i ne mogu baš sami da prolaze kroz život. U našem udruženju imamo terapiju podrške koju vodi naš volonter psiholog Saša Toskić. Imamo likovnu radionicu koju vodi naš volonter slikar Pavle Bugarski. Imamo i neke aktivnosti koje vode članovi udruženja. Naš korisnik udruženja Bojan Tomašević vodi neku vrstu literarne večeri. Projekte smo pisali uz pomoć drugih iskusnih udruženja i onda na kraju smo i koristili znanja koje smo stekli na raznim treninzima i gde se učilo o pisanju predloga projekata, pa su i naši volonteri bili uključeni u pisanje nekih od njih.
Ja sam Pavle.
Okay, I'm going to continue with the second clip.
Udruženje Duša je udruženje korisnika psihijatrijskih usluga. U početku je funkcionisalo uz veliku pomoć volontera i drugih organizacija koje su pomagale. Udruženje je dobro funkcionisalo, međutim kako su volonteri se povukli, udruženje je počelo da se dezorganizuje. Mnogo vremena su inače provodili s nama dok su volontirali, ali to je ima svoj rok trajanja, ne može čovjek večno bez stimulacija, što psiholoških, što materijalnih, da volontira. U udruženju Caritas koje nam je ustupilo prostorije, bilo je optimalnih uslova za rad, bilo je okej. Posle smo izgubili te prostorije, pa su nas šetali po raznim lokacijama po gradu. Udruženje, posle nam je prostorije ustupio IAN, International Aid Network, to je, ja mislim, neki vid nevladine organizacije. Trenutno se takođe u psihijatrijskoj klinici Laza Lazarević održavaju neke aktivnosti udruženja Duša.
Dobro, i što je to, na primjer, tebi ne odgovara, što ne ideš tamo?
Pa ja ne idem tamo zato što sam se lečio u toj instituciji i mislim da je svrha udruženja da nas istrgne iz institucija i da nam pomogne da se snalazimo, a ne da nas vraća u isto, tako da to je razlog. Zaista ne želim, osjećam se kao da sam ponovo blizu sledeće hospitalizacije. U udruženju Prostor imamo likovne radionice, imamo art terapiju, imamo psihoterapiju sa psihijatrom jednom u 2 nedelje, imali smo literarnu sekciju, imali smo radio emisije, imali smo Hearing Voices grupe preko kojih smo se upoznavali sa drugim korisničkim udruženjima u regionu. Kako može da se promeni stav društva? To je jako teško. Mogu kažem kampanja, ali iskreno u to ne verujem. Mislim, stav društva može da se promeni najviše tako što kao povezuješ takozvanu zdravu populaciju sa, da zdrava populacija ima aktivnosti sa mentalnim psihijatrijskim bolesnicima i takođe da se i oni zapitaju koliko su i oni normalni. To je to.
Prvo sam
Okay, thank you so much, Tamara, for your help with showing these videos, and thank you, Mina and Bosilka, for your great presentation, in which you told us really key elements of a successful user-led organization. I will just briefly summarize that in Croatian, then we'll go to questions, to a discussion. So, dakle, Mina je pričala o tome kako je njihova organizacija nastala, najprije kao grupa umjetnika vezana uz psihijatrijsku bolnicu, a zatim su rasli i postali dio nacionalne mreže, ali i regionalne mreže udruženja korisnika. I zapravo, da bi neka organizacija bila uspješna, važno je osigurati novce i prostor, jasno definirati uloge korisnika i profesionalaca, imati barem jednog stalno zaposlenog, jer u protivnom ne može se računati da će volonteri moći dugo nositi na svojim leđima neke zadatke. I to su nekakvi temelji na kojima može rasti onda uspješna organizacija. Mislim da sada zapravo možemo krenuti na pitanje. Imamo još jedno pola sata da prođemo kroz nekoliko zanimljivih pitanja koja su ljudi već postavili. So thank you all, thank you everyone, panelists and people attendees who shared their views in the chat box or posed questions. So let's start with a question from Victoria Bird from Queen Mary. She was referring to the video that Tihana showed about Menssana, and her words were that this is a lovely video and fantastic resource. A lot of members in the video were women. So how do we go about promoting involvement of men in the discourse about mental health? So it can be something that Tihana, if you want to say, if Menssana is only for women, or probably not. But if other people want to comment on how to engage men who are traditionally more difficult to engage in regards to mental health, please let us know your views.
Thank you. This is really important question, and we are all often faced with it. No, Menssana is not only for women, but the fact is that we found that male service users are more difficult to reach and to engage. We have maybe 5 or 10% of male members, but they tend to come only when for some specific and concrete needs and the specific and concrete contributions. So it's like people are directed to Menssana from centers to mental health, and usually even professionals tend to direct women mostly. So we struggle with that quite often. But these male members are really like concrete, and they can help a lot, they participate a lot, but just not in the way that women tend to be more open to speak in public and in front of cameras. They tend to stay behind the scene.
Thank you so much, Tihana. It's interesting that Mina is seeing a very different picture, right? In Belgrade, in your association, more men are involved and engaged. Why do you think that is?
I think there is more stigma regarding the female users as females in general. Maybe it's the mentality. I don't know what's the thing. Maybe like I have some, maybe like 70% are men and 30% are women. It's like this kind of, so I was also joking with Tihana, maybe we should do some common activities to, mix them together on a regional level. I don't know how to, maybe we were trying to attract women with the specific activities like knitting or maybe making some objects that are more attractive to them, but we will see. But
so what do you think would be activities that are more of interest to men?
I don't know. We have like painting, English, computers, hearing voices, but I'm not sure if that makes sense. Sport, someone said. Okay, yeah, sport.
Yeah, in Menssana we have a lot of sport activities, as you can see in the video, but they are not attracted to, to male members. But we tend to shape our activities by the interest of our members. So we don't offer them in advance, but users are leading all the activities. We don't have professionals leading activities, occupational activities in Menssana. So when we have members, then we discuss with them which type of activities they will lead or participate in.
So here we have a comment from Liliana Ignatova that gender-sensible programs can attract specific gender groups such as sport, football, basketball. Maybe that could be of interest to men as well. Professor Sartorius wants to add something. Could you please unmute yourself?
Well, I think it's not only males and females. It is really an effort to make sure that people are invited to do things which they can do well. If they are sportsmen, they should be engaged in sports, and if they are doing something else well, they are painters, they should be, to take them out of their role, which is socially defined, will always make it difficult to involve them. So that if you have people, the roles of males and females, but also different people with different education, etc., are very different. And in order to be willing to help, you must be feeling all right in what you're doing, not be lost in a new territory in which you've never been. So I think thinking about the capacity that people have, that should define in what way they can be involved.
Thank you. And it just occurred to me that we were talking about different organizations, Prostor and Menssana, who are very active, who have been active for years. But it's important to say that that in other countries, maybe organizations are just about to start with their work, especially after Tibet workshop that Mina mentioned. People felt inspired to set up organizations, and it will be interesting to see what are these initiatives leading to. There was also a comment in the Q&A box about setting up an organization. And Mina, I think you mentioned that there should be a professional to initiate a user-led organization, and Guadalupe Morales, one of our attendees, is saying this may not necessarily be the case. And she's mentioning her association of possibly people with bipolar in Spain, established in 2004, and many other user-led organizations who were from the start set up by service users rather than professionals. So there are different models, obviously, and it may work well in different settings. Maybe in Southeast Europe, given the still very paternalistic and traditional setting, it might be necessary to have a professional really sort of pushing it at the beginning to find money and space and things like that, and then users can be more involved later.
Definitely, I'm definitely not saying that the users, they don't have the capacity to lead the organization. No, I'm just saying that maybe it's from our experience, it's from this questionnaires that we collected from all the organizations, that we came to the conclusion that for the users themselves, it's much easier to have someone to deal with the administration, the money, the bank, the accounting, and things like this. Not because they're not capable of, I know also in the Hearing Voices movement, they totally, not reject, but they doubt the role of the professional. They don't need professionals in this way.
Thank you. We'll maybe come back to the management of user-led organizations, but there is also a question from Tomasz Gondek, who is a colleague from Poland, and it might be directed to Professor Sartorius, but obviously everyone else is welcome to comment. So this question is about stigma and fighting stigma, and Tomasz is saying, is it possible to fight stigma effectively if we universally agree that mental health is an extremely private matter and that there is some value in not disclosing own mental health problems? And in many countries, there are legal systems strongly supporting this view. Is perhaps being open about own mental health problems as professionals, could this change the perception of mental illness as something that should better not be disclosed and contribute to reducing stigma more effectively? Professor, we can't hear you, sorry. Yes.
That question really makes us to remember that educational institutions which want to create people who will be helpful to the health system must think what are the future roles, in what way they are going to be working. So that one of the shortcomings of medical training in general is that very little time is spent on educating people about ways to reduce stigma or many other things that doctors should know. Doctors are very often very poorly trained in very simple things. For example, how do you tell a child of 9 that until the end of his or her life, they will have to be injecting insulin because they have a diabetes? How do you break this news to a child? That is a skill that has to be included in the normal training, as many other skills. How do you tell bad news? How do you educate people to live with a problem, or maybe to live sometimes with a disfigurement, which is a consequence of a disease? There's a large number of educational that should be given to the acquisition of skills of being a doctor. Being a doctor or being a nurse or being somewhere else does not require only knowledge about diseases. It requires knowledge about life. And knowledge about life includes questions such as, how do I make people live with a disease which they have? Now, a specific point about whether one should keep the disease secret or keep the disease open and declare it. And in England in particular, but also in some other countries, there has been a lot of push to say, be open about your illness and speak about it, etc. And I think that is also something that people should learn in the medical school. They should learn how to educate people to know when and to whom to disclose their condition. They cannot tell it to everybody. I'm not going to a street and I'm not saying to everybody, I have hemorrhoids. That's not the way to do it. You have to think of whom you speak to, what are you going to tell them, what is your relationship to the other people. But to recognize when and how and what to say requires training in medical school. And unfortunately, that aspect of training is very often neglected. So I think that the fight for a more humane and more useful health system must include the revision of the education system in universities, as well as in service. Once people are in service, they have still to be brought back to learn things which they should know if they want to be good doctors. Or good professions in general.
Thank you. It's a very interesting topic, and also reminds me of those reports, I think from Norway or from also UK, when celebrities were talking openly about their mental illness and how this could help public to be more aware of.
Yes, but I mean, it's a different story. I'm immensely successful, so I can permit myself to say I'm successful, although it is for a person who is not successful to say, not only am I not successful, but in addition I have a disease. This is a very difficult and delicate position, and therefore one has to speak with a person who is mentally ill and speak with them and think together. What is the way that I can convey this knowledge, convey this information? How do I speak about this to other people? How much do I let them know? And that has to be learned and exercised with the doctor. The doctor must be ready to think together with the patient about ways of making life possible again. And very often doctors refuse to do this. All they do is treat the disease. But the word doctor as such doesn't come from somebody who is curing. It comes from the word docere, which means teaching. It's in fact the doctor has to think of ways in which he can help by teaching a patient what to do with his disease, how to handle his life when he has a disease and when it goes away.
Thank you. I mean, that sort of is very linked to some of the comments that we are seeing in the chat box. So Liliana is saying they made a survey. Sorry, I'm not sure what country are you from. They made a survey for people that use medications, and they showed that stigma is very very much present in North Macedonia in the medical sector, in medical and mental health sector. So people who are supposed to help service users, they might be stigmatizing them. If I'm understanding what you're trying to say.
Well, if I may join, during when we were having a survey, even in user-led organizations, professionals that are working with alongside with patients, with care users, some of them had like really judgmental attitude, like when we were questioning about the role of the users in the organization and which role they can have and they can carry. Some of the professionals claiming that they can like do cleaning or cooking, and that's it, like some kind of supporting services, which is really problematic. And that is why we have that kind of response that maybe professionals shouldn't even be in user-led organizations. So that we can change.
Well done.
Looking. Sorry.
There has been done very good research which shows that not only doctors, but also nurses and other health personnel very often contributes to the stigmatization by a variety of things. And very often they are not of ill meaning. They just not even aware what they are doing. They are not aware that by calling somebody schizophrenic, they are doing a major error. They should think of the person who is behind them, before them, not about only the disease as defining the person. And I think that the self-awareness, being aware of your own behavior and of the effects that your behavior will have, is a very important aspect of practicing medicine. As a nurse, as a doctor, as a social worker, whoever it might be. What we are doing is in fact contributing to the image of the people whom we are treating. And I think that that is not sufficiently emphasized and not sufficiently changed, because many of the children enter into school and subsequently the university carrying all the prejudices of their family and prejudice of their community all the way into the end of their schooling, and they retain prejudice which they have to actively change if they want to be doctors deserving the title of doctor.
The question is how much of that can be changed with education, because also I'm thinking that specifically psychiatry, being a field with for which there are not necessarily much interest, and there are always vacancies in psychiatry, right? That some people will end up training for psychiatrists who don't necessarily want that. They were not able to get something else in terms of their training. So they end up being trained as psychiatrists and may not have these qualities of skills that would actually make them, you know, able to treat people with respect and understand their needs in the best possible way. Absolutely. How can that be changed with education? Can that be changed with education?
Well, some of it can't, in which case the real responsibility is who do you select to allow them to do postgraduate training in psychiatry? Who can become a psychiatrist? Not everybody is fit to do every job within medicine. And it would be a basic responsibility of a teacher to say, I think that you will have difficulties in doing this job. Don't do surgery because you are not fit for that. You will probably have difficulties, or any other. The advice that you give to people at the beginning, at the end of their medical career, or even earlier, should include your view of where will that person be most useful? Where will that person give the most of himself or herself? That is something that is neglected. Everybody can go wherever they like, but it's not true. They become bad surgeons, they become terrible gynecologists, they become bad psychiatrists because they are not in the job which fits them. And fits them means that it's not in harmony with their personality, with their way of behavior, with their background, with their culture, and with the way in which they live.
Thank you. So we have some time to see, to think about other questions that are popping up. So Mariana Pinto da Costa is asking she's saying that this is a very interesting work, and she's asking, what obstacles do you think there might be around the sustainability of these initiatives beyond the duration of the Impulse project, and how do you think these can be overcome? This is a brilliant question, and definitely something that we've been all thinking about. Sustainability is always an issue. Any thoughts from Tihana or Mina, or maybe Professor Sartorius? I mean, you've seen in your career these organizations and initiatives rise and fall, right? So what makes them sustainable?
Well, I don't want to monopolize, so please I'll hear first what my colleagues here at the say, and then I will also say what I think.
So Tihana and Mina, what do you think about sustainability of your organizations, or possibly, you know, these panels for advising researchers? Is this something that once Impulse is completed, is this something that can go on, or not? What are your thoughts?
Right now we are in the third year of leading project of Drop-in Center, the care center for users in mental health, which is about the time that you begin to collect the resources from the projects, and after 3 years. But there is also results that can be shown for fundraising from local communities. So I don't know if it is a good approach, but it is from our experience. We tend to communicate with local communities and smaller level of government, small level of nižim vlasti zapravo, like, so yeah, like municipalities and local cities and that kind of government level. So that is our so what we would advise other associations is to maybe such as we did begin with project funding, but also to have really good research of the input and output, and really to have got good results after those fundings are spent. So you have to show something. So if you are starting a user-led organization on any kind of NGO, it is important to measure incomes at the beginning, and really to fight for that. And the other way of sustainability is the effect that we have already made to our users, that it will last even if some of the organizations are closed.
Mina, do you want to add anything?
Well, I could say only from a different perspective, because we are not connected to any kind of governmental organization in any way. So now we are carrying out the project really about advocacy. So we're trying to license our service to make the service more visible. So I think it's important to make this collaboration between the government, between the NGOs, and between psychiatric institutions, because the psychiatric institution, if they recognize us, then we have more credibility, I think, in the eyes of the government. And the only way to be sustainable is to be recognized officially, I think, at least here in Serbia, because we are surviving from project to project. So I think this is not really good for our beneficiaries, because it's not stable. We need to provide some kind of structure and secure regular activities. So this is something that we are working on now, and we're doing research about the positive effects of psychosocial community activities to the quality of life of our users. So I think if we use all these documents and findings, we will have this base for the sustainability. And regarding the leaps, I think that it's a good practice that can be used in other research projects. So maybe if Queen Mary University would spread the word that this is a good practice, so the other people who do research in our region might use the same leap groups, maybe this can continue on in a way.
But when you say that you want to make yourself visible to the government, what does that mean? Can you expect government to give you funding for, I don't know, 5 years? Or is there experience with other organizations, maybe outside mental health, that they can get this kind of contracts or
it's more
agreements with the government?
Yeah, not really funding. Maybe, I mean, I'm not politically active, so I cannot hear in Serbia. If you're not politically active, I doubt you can get funding. But maybe to be recognized in a law of social welfare as a recognized service in the community. So this is one way. And then maybe if like our government has the obligation, they're like obliged by the European Union to maybe push forward more the community mental health, maybe they would provide like some premises for us, like they have free spaces that they don't use, or maybe in the future, I don't know, they will pay like for basic services just to pay for us to survive, and then we can write projects. So there are different, there are different experiences, because some people, they're involved with the government, other people, they maybe have experts in writing projects, so it's different. It's like really a big scale.
Thank you so much. I think Professor Sartorius, you wanted to add on this.
Well, it's the central problem for so many projects. I have divided this in two parts. One is a question of an attitude. I think that in any project, you have to attune the role of being a cheerful pessimist. Things will break, but although they break, something will be left that you can use and develop. And I think what we can do in the course of a existence of a project, we can create converts. We can convert people who believe in what they are doing, who will themselves later on expand and continue with the work that happens. You somehow convert apostles who will then take on the thing and do it in their own way and in their own place. Maybe your project will be dead, but what will be living is people who participated in it and who will sooner or later, many of them, in fact, do something on their own. So that's one aspect of it. And I think that's for any project in the world. But more concrete, in coming back to what Mina has been saying, I think that assembling information that what we are doing is useful is very important. How do you say that? Well, part of it is research that you can show by research. Part of it is experience that you have people who can speak about this with enthusiasm and say, yes, my brother has been there and he is now a different person. Partly, it is also the influence of Queen Mary Hospital, who will say, out of England, we know that there is a thing in Belgrade which does this work so wonderfully. So that is, you assemble goodwill from various sources and you store it up, you stoke up goodwill, so that as time goes by, that goodwill is your ammunition with which you can shoot to continue the project. But being in that position is for all projects, and it's becoming more and more common to see that people have nothing stable, but they keep having these things which exist for a number of years and then they vanish altogether. But I think those two aspects, on one hand, being aware of the fact that you're creating converts, people who believe in what you're doing, people who speak with enthusiasm about this, I think is a very important aspect. And then the other aspect is also good evidence. And then there is something that I think Prince Philip now has just passed away. From the day when Prince Philip has been acquired by the World Wildlife Fund and the Protection of Environment, within the week that he was there, all of a sudden also started happening. But to convince him to become that was a work of art. And I think the same is true for many of our associations. You might, for example, get an interest of an important politician and give him some recognition and stuff like this. He becomes more interested and more likely to protect you and be with you and perhaps say a good word. I think that the continuous effort to get friends and to befriend people is a very important aspect. We cannot only help people who are the members of our group. We must also think of how to engage others to see that what we are doing is useful.
Thank you very much. Thank you to all of you, to all panelists and all attendees. This was a very interesting and fruitful discussion. As said before, we will be posting this webinar on our social media. And here I'm trying to share that again. I don't know if I'm able to. So we would very much like you to stay in touch with us and with our work. These are contact details, so please drop us an email or get in touch if you want to discuss anything further. Hvala puno svima što ste sudjelovali na današnjem webinaru. Nadam se da vam je bilo od koristi i da ćemo ostati u kontaktu. Ovo je naša internet stranica i linkovi na društvenim mrežama, pa će nam biti jako drago da podijelite svoje impresije i da nastavimo kontakt i suradnju. Eto, hvala puno još jedanput svima i do nekog sljedećeg viđenja. Thank you all very much and have a good evening and rest of the week. Thank you.
Thank you. Hvala.
Thank you, everyone.